and answer our. And thank you so much, Dr. Mahesh. Sir has been waiting for such a long time. Thank you so much. Let me just give you a very brief introduction. Dr. Mahesh Kappanayil, Professor Pediatric Cardiology, Amrita Hospital, Kochi. He is also the head of AIMS 3D Printing, AR and VR Lab. And he is our Dr. Buddy. He's been a source of inspiration right from the beginning when we started this project of Justice for Heart Warriors. And all the questions I've already sent to you. So now it is the ball is in your court. Let's play it on. Yes, sir.
Thank you, Sajni. Again, I hope I'm audible.
Yes, sir, you're audible.
Okay. So, Sajni, first of all, congratulations to you and the entire team for putting together this session. This has been absolutely amazing. I mean, even for all of us, I think this is some of the best, most valuable time that we've been able to spend with the group of all of you out here. And this is a great endeavor, and we need a lot more of this interface between the physicians and the patient families. Often, we participate in so many medical conferences where it's groups of doctors discussing about, various diseases, treatment modalities, etc., etc. But what is always missing in those conferences is the perspective of the people who are receiving the care at the end of the day. And that's been something that we've been trying to advocate also, that most of our medical conferences should definitely have a segment where we get to actually listen your side of the story. And that's been a missing link for all of us, like forever. And this is an absolutely fantastic opportunity, not only for you all to interact with physicians, but also for us physicians to hear from you. The stories that were told by Amod and Tarana and Srishti and Rajdeep, they've been absolutely eye-opening and soul-opening. And it's some of you like Hari, Sajni, Appu, I do know your stories personally to some extent, but then you really get to realize how different and yet same the stories can be across people and subgroups. There have been a few common themes that we've heard during this session. One of them has been this angst as to why me, why with my child. And second, there has been this angst about, how come despite all the care that you took with your antenatal scans, still the diagnosis of congenital heart disease was missed. I think that has been a recurring common theme, isn't it? That you did your best, you went you did your scans on time, and still how come this was missed? So one of the major reasons for that is that the fetal echo is a very specialized test that requires a very highly skilled imaging personnel. It also requires a specific kind of machinery and technologies also, because even the scanners come in various grades and there are various types of scanners, etc. The routine antenatal scans or the anomaly scan is usually not done by cardiologists or people who are specially trained in fetal echo. They're trained by ultrasonologists, radiologists, and often gynecologists and obstetricians. And though they are trained to look for anomalies in general, but analyzing the human heart in a fetus can be incredibly difficult, even for us with decades of experience in pediatric cardiology also. Sometimes it can be very tough, because you can imagine your heart is like the size of your fist. And now you imagine the size of the fetus that is growing inside it. So, like 14, 15, 16 weeks, it's really, really tiny. And then the blood vessels coming from them are even tinier. So it is incredibly difficult and does require some training, some equipment, and a kind of a structured approach to it. That's what comprises fetal echo. It's often not possible to ensure that level of quality across the general antenatal scans that happen. And that's one of the reasons why this can be missed. Second is also that in an expert hands also, sometimes the fetus is very mobile. Fetus is moving inside the mother's womb, and you are trying to see the fetus through the mother's tummy and through the uterus down into the baby's chest and the heart. And even in expert hands, sometimes it's quite tough to identify the heart diseases. But yes, in most cases, if a fetal echo per se, fetal echocardiogram is a specialized test, it's different from the antenatal routine anomaly scans. But if fetal echo is done on time, it can identify and recognize most of the congenital heart disease well in time for you to take major decisions regarding future care. Now, fetal echo is not recommended for everybody because, like you yourself said, pediatric cardiologists, pediatric cardiac surgeons are few in number across the country. Similarly, people with the kind of expertise to do a comprehensive, very accurate fetal echo are also fewer in number across the country. So every woman, every pregnant woman may not have the access to get a fetal echo scan done. But wherever the anomaly scan raises a suspicion that there may be something amiss, usually patients are referred onwards for the fetal scan. And if it is not suspected at that level, that may not happen. Second situation where fetal echo does happen is where there is a suspicion of genetic abnormalities, or there has been another child who's had a CHD, or if the parent himself or herself has had a CHD, then there is an increased indication for doing a fetal echoes very specifically. So these are situations where fetal echoes are done, and in most cases we can pick up these kind of critical heart diseases. I know that this does not really solve the angst that is there for each of you personally, that in your personal case this was missed, but we hope that things will improve in the future. For example, in Kerala, my colleague Dr. Balu, who is a fetal echo expert, has really been fighting for this. He's involved himself with the government of Kerala, and there has been a campaign to actually train the people who do these routine antenatal scans, which are the gynecologists, obstetricians, and radiologists, in how to identify heart disease accurately. So we have created a kind of a structure, and there have been several training programs to really encourage them to look at the heart in a way that these diseases are not missed. Hopefully, in the times to come, this kind of endeavors would be taken, nationwide and even globally, so that more and more people who are involved in routine antenatal scanning will become better and better at picking up heart disease very early in the pregnancy, so that the families are better prepared and they know what to expect and can take action in advance. So this is the first concern that I wanted to address right at the first go. And Sajni, I think we can make this relatively informal. We can have some questions coming and going, and as and when necessary, I can refer some questions onwards to my other colleagues present here, Smita, Dr. Navneeta, etc. also.
Okay, sure, doctor. I mean, I'll just ask the questions, and I hope you people can decide which question to choose and ask. Select and answer. Right. So the first one is a CHD, the issues, the future, the physiological, the psychological, and general conditions. In conditions, the child should be ready for pre and post procedures, evasive or non-evasive. What are the issues he might face as he grows to an adult? Yeah.
Like some of the sessions have already talked about the CHD. When we talk about it, it's not like one disease, as we've talked about it. It's a whole spectrum of various kinds of heart diseases. And so the way the disease would progress, or the treatments offered, or what happens in the future depends a lot on the specific type of congenital heart disease that you or your child has. So it's very important that when congenital heart disease is diagnosed right at the outset, it's important to have a very good deep conversation with the doctors to really understand what the heart disease is about, what are the implications. There are diseases which are correctable. That is, you can completely fix them through either open heart surgery, or sometimes even by just transcatheter procedures like device closures, etc., etc. And then for the rest of your life, you're actually fixed, and there are going to be no major issues. Even then, we do keep a certain level of surveillance. There is a follow-up. There is a structured kind of a follow-up, so that you're always, there is always a view on how you're doing in the future, and there's documentation that you're doing well. But other than that, many of these diseases can be completely cured. Examples would be, having a PDA, or an atrial septal defect, or a ventricular septal defect, etc. If repaired in time, it is practically a fix for life. Even many complex heart diseases can be completely repaired, even the newborn period. So not every heart disease has to have a very complex long-term problems. Many of them can be fixed, but even then, it's very important to stay in connect with your treating physicians lifelong, so that all the problems that come up in, if they come up in the future, can be identified early and addressed. And the complex heart diseases like this, the where you need stage surgeries, etc., there are specific problems that we address as the time goes by. Broadly, we call them as, like you've talked about, single ventricle and biventricular hearts. So what we mean by biventricular hearts is that when you fix them, you have the shape of the heart is practically like what a normal person has, right? So you have one side of the heart that is to pump impure blood, the other side of the heart is to pump pure blood. So the heart, once repaired, is working like a normal heart. Single ventricle, or the Fontan pathway, as we say, like, so that is where the heart cannot be converted into a state where there are two different parts. So where what we do through the Fontan surgery is we let the heart do the work of the left heart, which is to pump pure blood into the body. So we do this in a staged way so that the other half, the work of the other half of the heart, which is to pump impure blood into the lungs, that is substituted by creating this new circuit, or the Fontan circuit, where the impure blood actually bypasses the heart, goes directly to the lungs, gets the oxygen and comes into the heart. Because in most of these cases, you only have one ventricle instead of two. So we give it the work of pumping blood into the body. Okay, so this is what is the Fontan circulation. So this Fontan circulation has its the advantages that, yes, now you have a functioning heart, it is working very well, your oxygen levels are nearly normal as anybody else. The limitations are that, yes, there is lower stamina, you cannot do very strenuous activities, there are certain lifestyle limitations, and there are a set of things that one needs to take care of in the future. Okay. And so those are things that we need to understand from individual to individual and heart disease to heart disease, and in conjunction with your physicians, carefully understand and then follow through with these actions.
Thank you so much, Doctor. And actually that gives the answer to the second question, which was actually Fontan versus non-Fontan CHD warriors, challenges and chances. So that answer also, that question also stands answered. So we'll just go to the next one, which is about like, why do ultrasound scanning during pregnancy? So that is also covered. Yeah, what is contradict? Yeah, this is a question, like, I don't know if it is right to say, but why is it that contradictory treatment plans are suggested by doctors? What kind of action logically is to be taken by parents when faced with this dilemma? Because the problem would be one, but even in the same hospital, two sets of doctors would say, give the parents two different advices. So how does a parent actually, because parents are laymen, they don't know the technicalities of it, how do they decide as to what to go with?
I can totally understand the confusion that a parent would face when, faced with, two divergent opinions on the same heart disease. So the reason why this happens is that for simple heart diseases, there will be no confusion like that. I assure you of that. If it is simple BST, AST, PDA, anything falling in the simple spectrum of heart, there will be no confusion anywhere in the world. The answer would be very simple and the procedure suggested would be common across the board. Where there is a divergence of opinion is where the heart disease is more complicated. And there are possible multiple ways to find a solution or to reach a solution. Okay. So in these situations, there are multiple factors that come in. Age of the child, the precise nature of the complexity of the heart, the technical difficulties in addressing that heart problem, whether to fix it completely, or whether it is too difficult to fix completely into a biventricular heart, therefore to choose the pathway of the Fontan circulation, which is technically simple, but has more long-term, things to look out for, costs of the surgeries, the socio-economic situation of the family itself. So all these factors, as physicians, when we look at our patients, we are not just looking at that one report. We are trying to see what solution we can offer to this child for now and for the long term. So this is where the dilemmas come in. And often it is not just a technical dilemma, it is often a moral dilemma also for us. So, and it's therefore, like in our own institution, we have a system that, every Saturday, the whole team of doctors gets together in what we call as the joint cardiac meeting, where the surgeons, the cardiologists, the anesthesiologists, everybody sits together as a group. And the intent of this particular meeting is that whatever cases we have seen through the week and who are pending critical decisions, we put up all this information for a discussion in the group, where all the pros and cons of each patient's case, what is the disease, what are the possible solutions, in this particular case, which would be the best solution. And believe me, there would be differing opinions, even in our own group. One cardiologist would think that no, we should go all out and do a very complicated surgery and try to fix this. The other may say that no, this kind of an approach is too risky and it may not give benefits in the long term, so we should perhaps choose the easier option of going down another pathway. A third person may say that no, we should not even try to intervene here, because even if we do a surgery, it may not really improve the quality of life in the future. So these differences of opinion are quite normal, and it happened in our own group also. And therefore, we try to bring in an additional check by having these kind of meetings where we discuss, and then we actually document that the discussion happened, all these factors were discussed, and we have come to a final decision that this is what we're going to offer to the patient or the family. The decision is a collective one, and it is based on our best judgment. So to cut the long story short, it is possible to have very different opinions on the same heart disease, but this usually happens in the more complex category of heart disease. And I can understand the family being confused about this thing. What they should do is have a very clear, open discussion with the treating physicians as to what is this decision about, what are the alternative options, why is this option being chosen for me specifically. So those things, if you understand better, then you would be better aware of what's happening. And there's absolutely no harm in taking a second opinion, asking other experts in the field. When we take a second opinion, it's important that seek out people through various networks who would be people who would be able to give you an expert opinion or a knowledgeable opinion. Because not everybody, not even doctors, not everybody would be aware about the complexities of the decision making in these cases.
Okay, thank you so much, doctor. I hope I'll just move on to the next question. And the next one is, when a child or adult is detected with CHD, is a patient liable to all the information, including risks and future complications and consequences of not following up? If so, are they educated by the hospitals? There is another thing to it. At times what happens is one particular problem regarding the heart is corrected, but then some other organ starts getting trouble. Right. So I was asked to choose between the heart and the kidney. So I said I want both, and I left from the hospital. So I mean I don't want to sound like this, but this is actually what happened. So treating a particular organ compromise another organ. Is there any way where this doesn't happen?
Sajni, to answer your primary question, absolutely, you have the absolute full right to know everything about the disease or whatever pathology is diagnosed. Absolute full right. And it is your right to speak to your treating physicians as many times as you need or as you want. And it is the duty, our duty as the physicians, to explain things to you in the greatest possible detail. And if we do not do that, it is our failing if we are unable to really explain things to you. Sometimes, in the real world, it is possible that physicians may think that a family is unable to really understand the complexity, so they may try to put it in simple words, or really dumb down the whole issue and try to explain it away. But that said, you at the receiving end have every right to sit down and demand to know more and get full clarity on it. And that, I think, is very important also, because many a times when heart disease is diagnosed, one is in a very, very dazed state of mind, and one finds it very difficult to accept what has just happened and being given a diagnosis of heart disease. and it's difficult to really think through it. And sometimes even when we are speaking to the patient, we can see that they are completely off, because you're thinking of so many things at that time, and you're not even listening or able to understand what the doctor is saying. In such situations, it's always wise to go back, have a cooling down period, and then think about it deeper, and necessary come back, speak to the doctors, understand in detail what exactly it is. What are we talking about? What are the options ahead of us? Why? What is the advantage, disadvantage of each of these options? And it's very, very important that you exercise that right. That will also make us as physicians more confident in treating your heart.
Okay, thank you so much, doctor. Moving on to the next question. Yeah, why is there no social security system or health insurance for the adult CHDs? There, like, I guess this question has been already taken by Smita ma'am, so I'll just move on to the next one. Is there any specific lifestyle a CHD child or adult needs to follow to increase the lifespan and prevent infections?
Again, I think Dr. Amrita also covered part of it, that,
Yeah,
and
taken,
Smita also, that, not every heart disease is the same. There are very specific recommendations depending upon case to case and disease to disease. And there are no blanket recommendations in general. Even for people who've had a certain kind of heart surgery also, depending upon that person's fitness and overall environment, nutrition, I would advise that person specifically with regard. And there are different people with different interests also. There are, not everybody, not even me, I'm not an athlete. And it's not as if, every person with CHD is trying to be an athlete also, right? But there are people who have certain interests where we are able to guide them properly. Okay, you can do certain things. These are the set of precautions you need to follow. Again, I think communication is super important. Broad guidelines may not work because of the very specific nature of congenital heart disease. But yes, if you communicate with your treating team, you can really figure out what kind of lifestyle modifications to take. And of course, other than that, the general healthcare advice, general lifestyle advice, I think it's because one already has an issue with the cardiovascular system, it makes sense to follow a general lifestyle that is cardiovascular friendly, right? Be it in terms of diet, be it in terms of exercise, rest, sleep, etc., etc. Those do go as common guidelines.
Do we have any like manual or any handbook or something that CHD association or something can provide regarding this?
Not that I'm aware of that there would be a manual on this, but I think again, like as per individual heart disease, please get in touch with the physicians to really understand what is the physiology, what is the heart disease. Have you been totally fixed? For example, if it's in VST who's been completely fixed, he could do anything. He can be even an athlete, right? So depending upon that, there are kids who have had heart surgery, who've gone to they finish their PhDs, who are doing brilliant in their career, who are brilliant artists, where they're able to do everything that their passion is calling for, right? So it's just important to understand.
May I intervene?
Yes, Smita, please.
Mahesh, so many seriously, like the one thing which is even for the simpler heart disease post intervention or even pre-intervention, where we say that there is no need to go for any intervention after a while 10-12 years of age, a simple TMT can be very indicative that of your functional capacity. So can be done. And we keep on doing it for the valvular heart disease and all, where we are letting go a person for the pregnancy or anything. So the simple functional evaluation is important. We can do that.
Thank you so much, ma'am. And let me just move on to because we've got like 15 minutes time. Like I'll just rush up to the next question. In the situation when faced with an emergency, what is the first aid a caretaker can give, and is there any common emergency number where help could be available, as a hospital would be too far for the child to reach in time? What to do in such a scenario?
That's a tricky question because again, it depends upon the type of heart disease one has. For example, if somebody has had a BT shunt or a PDA stent, those babies are at risk of a blood clot really compromising the flow into the lungs, and suddenly a baby could turn very blue. There could be a baby with TOF or tetralogy of Fallot, where one could have something called a cyanotic spell, where again the oxygen levels suddenly fall and baby becomes very blue. And of course, as a first aid, there are a certain set of actions we do tell the mothers. If a baby has a TOF and is having something called a cyanotic spell, we do tell the mother to immediately hold the baby in a position that the knees are folded against the chest, try to calm down the baby, but at the same time try to seek medical attention as soon as possible at the nearest center possible. And the families who have a risk of facing these situations should try to have the number of the nearest medical center that they can go for help in case something like this happens, and be aware of where such help can be sought. Now, Nita, do you want to add to this anywhere?
Yeah.
Yeah, I mean, unfortunately, we still do not have an organized system which would cover across hospitals or systems. But I'm sure that each treating hospital will have a way of dealing with emergencies. Like in Amrita, whenever we discharge patients, according to their needs, we would be telling them what all are the specific things that they have to watch for, and what are the danger signs especially. So as has already been mentioned, in tetralogy of Fallot, spells are something which we would want the parents to watch out for. If it is a situation where the baby can go into heart failure, then we will be telling them what are the things to watch out for. And so this thing, the danger signs vary from physiology to physiology, and accordingly what we can do in each setting will also be different. And what I would tell is it's important that you, whenever you go to any particular healthcare facility, you should understand what is the way to contact them in case of an emergency. Is there a phone number where we can, that is how we are handling it. There is a number where, our patients can call and talk directly to a doctor if needed. So I'm sure that every healthcare facility will have a system like that. And that is currently what we have actually. And it is important you understand about the disease yourself so that you will know what to watch out for, so that if a situation arises, you will be able to deal with it. Sometimes I even tell parents that you can go to the nearest healthcare facility and tell that your baby has this particular heart disease and this particular procedure has been done. And if this happens, we have been told to look for this. So, we can empower parents to that level. So even if they can't reach the tertiary care center in one go, even the nearest hospital where even an adult cardiologist is available, if they can be primed about what to look for, they'll be able to help in an emergency. So these are some of the ways where we can overcome some of the deficiencies in our healthcare system, where we don't have an EMS number to call in the Western societies.
Absolutely, Navneeta, well spoken. So I would also appeal to people like Hari and others with the creative ability to maybe probably even think of creating systems where there is an emergency number, which are driven by the location and the available facilities around, so that it could be an app, it could be a database where it's easy for a parent to quickly seek help from where they can get some basic expertise.
Yeah, thank you so much, Doctor. I mean, the need for a common database and a common number, it's really, really important, because that is one thing that we all look forward to, because our kids, when they grow up, they go to different towns, different places, and we really do not know how safe they are. If there is an emergency number, yeah, it would be so good. And if the name is saved in the database, even if they meet with an accident or something, immediate care would be given. Or else not knowing that they have a heart condition, if something is done, it's risking their life. So
I'm sure we can create something like that in the times to come, because technology will allow us to do things like that. So yes. I think in the times to come, we would be able to create systems like that, where it's easy to access help and get precise help.
Yeah, thank you so much, Doctor. Moving on to the next question. Yeah, that was actually about networking itself, networking of hospitals. Now, is it possible that each and every, in government hospitals and all, when we have gone, it's every time we meet a different doctor. Private hospitals, we get a doctor, but then the procedure is so expensive. So if there is an umbrella system wherein all the doctors can be connected, all the hospitals are connected together, and basically the health of the student, I mean, of the children, that's most important. So if a system is like that wherein even if a patient is registered in a hospital and they can avail the treatment at a lower cost or from a different hospital, depending upon the economic status or the severeness of this condition, which a particular hospital would be good. Is there any kind of networking that is possible that way?
I think again, this should be something for the future where we create more, more flexible, more a network of institutions, hospitals, which are able to provide the care and have the patient the ability to get information about them and being able to access them. I think these are system improvements that need to come in rather than each one working in a silo.
Yeah,
Multiple institutions working in a silo, and this is a real problem. What you're saying, that you don't have continuity with the physician that you're seeing. You find it difficult to travel all the way to another hospital, etc., etc. Of course, we have to understand that not every institution and every team would have the same level of expertise. Also, there are centers which have very high level of expertise who are able to manage really complex problems, whereas a lot of other institutions would be able to handle simple problems but would not have the wherewithal to handle extremely complex problems. So again, there is a difference. So there will be that difference in the level of expertise, infrastructure, etc., across institutions. But at the same time, I think yes, there should be better systems where there should be better communication between institutions and more willingness to actually work together towards the common good.
Right, doctor. That's really the need of the hour. We are going to 5G and so much of technological advancements are happening. So at the hospitals, it would be so nice for the parents and the kids, and generally the medical care needs an upgrade. Everyone has to have, not just the congenital heart defect people, everyone has to have a medical card wherein all the details regarding their health could be there, and they could avail a medical facility anytime, just at the press of a a button. That is the ideal kind of thing. Yeah.
Yes.
So the next question is about, this is like a question which came to my mind so many times, like some test is done, like an echo is done in a hospital, and we have to take the kid to another hospital immediately. Maybe it is just a week apart, and again we're asked to do the same thing. What is the validity time of this, or is it like mandatory that every hospital, all the tests has to be repeated when already you have got tested and you're carrying the report? Why does this happen?
Right. So, take for example something like a blood test report. You got your blood test done from a lab. So the lab gives out a set of readings, and they're pretty standard, and they can be interpreted by anybody who sees that report. Even an X-ray or an ECG can be something like that. It's been taken, and for that moment, you have the record of what was found on that. But some of the tests, like echocardiograms and angiograms, are very operator dependent, and they depend upon the knowledge, the skill, and the way the echo was done by that particular operator. Okay, that's the main difference between, say, an adult cardiologist doing an echo for a child with CHD versus a pediatric cardiologist doing. Both are cardiologists, but the adult cardiologist has been trained in a different way to look for a different set of things. So even though they may be able to look at a pediatric echo, but they do not go through the kind of rigor that a pediatric cardiologist goes through, because there are, like, heart is made up of various different segments. So we ourselves go through a lot of training to go through that checklist to accurately identify all the problems. And again, the echo is a very operator dependent issue, where how you keep the probe, where on the patient chest, what are you looking at, how do you angulate it, the images that you get can be very different. And so is the interpretation of those images. So which is why echocardiograms often are repeated by the experts, because that judgment has to come from within them, because they're going to take the next stage decision about whether this patient needs a surgery or not, or what kind of care is going to happen to that. So it's extremely difficult to go by an existing report which is already there. You need to see, again, before taking these important, crucial, life-saving decisions, you need to really understand the internal anatomy, the functioning of the heart, how the blood is flowing, whether an intervention is needed, how soon is the intervention needed, what will happen in the future. etc. And it has to come with a very individual perspective. So that is the reason why this echoes are often repeated, and that's really necessary to come to a good decision. Similarly with angiography also, it depends upon how the operating team conducts that angiogram, the kind of information that you get. And many a times these are dynamic information. They keep changing with time also. Suppose an echo has been done a month back, or an angiogram has been done, say, 6 months back. Some of the information that was got at that particular time may not be the same right now, because the body, the heart, everything is adapting and changing in response to the heart disease, right? So therefore, it's from the patient perspective and from our own decision-making perspective, it's very important sometimes to look at it again. In a large number of cases. That's the reason why we often ask them, okay, oh no, we need to repeat the echo again. It's not like the simple blood test or an X-ray film which you can just see and interpret.
Okay, next time we take an echo, you'd be feeling like, okay, this is fair.
No, it's very important, because that really goes into, because an echo is, you do a lot of intellectualization when you're doing the echo. You're trying to understand what's going on with this heart. What is this? What is happening to the heart? What is happening to the baby? What do you need to rectify that? And as treating physicians, it becomes our utmost responsibility that the decisions that we take should be really accurate, and we own the responsibility for it.
Yeah, perfect. Yeah, that is owning the responsibility. If echo is done based on that, you would be like doing all the procedures. Correct. So it is very important that it has to be done at that particular hospital. Yeah, that is right. And now the next one is like, this is something which I don't know how to put it across, but basically, how do we do this? How do we push the agenda for more hospital, better infrastructure, better conditions for doctors in pediatric cardiology, more doctors, balanced job hours for the doctors, better pay packets and perks, upgraded government hospital, inclusion in health insurance policy making? The whole thing is included in this question. But I mean, what is the reason that the government is shutting the eyes or ignoring, in spite of the huge picture of the fact that 1 in every 100, one child born out of every 100 has got this particular thing, and adult, not much of a research is done in adult congenital case. What can we people do to push this agenda? How can we make the government to just open their eyes and address this? At least have a common platform where we can talk with them and tell them, okay, these are the problems. What are you people? What can we do about it? Not just them, all of us. What can be done regarding this? So that's another question.
I think you've made the right start in this, because we need your support in doing this. The voice has to come from you, that the need that, that has to be felt by the governments, because the government has so many other priorities, right? So until and unless we, really advocate for the needs, it is often not heard. The governments, both at the state and the central levels, have to really understand the priority of, of congenital heart care. And while physicians and teams of doctors can keep on advocating for that, but I think the strongest voice comes from you, where the patients who need this, they have to come forward. Often what happens is that, care, one goes to the hospital, gets the care, goes back. Now look at all of you. You are actually collecting together for a cause that is greater than your own, right? You're not just talking about treatment of your own child or yourself. You're talking about trying to improve systems, trying to advocate for improvement from the government. That is the critical need. That's a real important need, and that's what really makes governments also wake up and policymakers really become aware. And of course, like Dr. Smita has very clearly outlined about how she's struggled, push certain, policy statements forwards, to get insurance coverage, etc. It is challenging. Of course, the red tape is there, the bureaucracy is there, the government setup is there. It's difficult to push things through, but at the same time, I think collectively we'll be able to make enough noise to be heard. Dr. Smita, you want to add to that?
Yes, Mahesh. Hello.
Smita, can you add to this particular
Mahesh,
question on how to make?
I am like a little, maybe seem like dreamer, but in 2016 I made an idea about the bringing a health television with all social media attached, with all group of the doctors over there, and to ready to do 1 hour OPD every day, and the partnership with the various conferences, and of course the medical condition based the serial and all. So I made everything, but the problem was you need around say 20 crore rupees as a first investment, which I was not able to collect. So still I think that one day we will be able to do a YouTube channel based health program, where we actually give proper OPDs also, and we make use of social media. And like everybody is having smartphone, like a baby is sick in a very remote area, somebody can show us, send a video, and we can know that it may be a spell, cyanotic spell, and we can work, we can provide the basic instruction to local person, whoever is medical person, so they can take care of that baby. And then we should have a ambulance, and also we can provide the ambulances also, and we can
So
find
again,
out
we
which
focus on,
hospital will be nearest.
yeah. So again,
So
basically
that kind of
networking, advocacy, using technology appropriately, we will
technology,
be
and
able to find
smartphones are
the
such a big technology, we have started a child literacy group also in Delhi. So we are just making the around say 20-30 students from the every school. They have been given certain kind of pulse oximeter and all those things, and they have to take the pictures, and they have to connect with their elders in family, their teachers, or maybe the local health facility. So this is what we have started doing.
Sunil sir, you want to say something upon this?
Yeah, I just want to say regarding inclusion in the insurance schemes. See, there are companies which provide insurance schemes, so like person working in ONGC, and some of the good IT firms like TCS, Infosys, they all come with the insurance schemes which provide surgery, pre-surgery for CHT. Somehow our local insurance, Star Insurance, and I don't know what it is. What we need to find out is how this insurance, these companies, this CHD become viable for them. But is there any high premium for that? So that part we discuss with the companies that don't provide, because majority of the insurance in India is done by, I don't remember the other names. So that is why I'm telling Star and other names. So why they are it is unfeasible for them. Why it is feasible for certain companies?
Yeah, ma'am.
Hello, like ICIC Lombard started a family coverage for the JNK, and there all the kids, all the babies were covered under that, all the population was covered. But then because it was a government thing, so it was very lucrative for the agency, but once the payment part came, then there was a lot of corruption, so they have to withdraw that scheme. So that is the biggest culprit, that corruption part, because unless, as I said, unless government takes the insurance coverage instead of direct financing, things will not move. So that is the most important part.
Yeah, I totally agree with that, because until and unless policy making, like a changes, a major change is done over there, funding is a major issue. Like all the survey forms we got, basic thing was having a congenital heart defect person with us. It is like having a huge financial burden. That's a fact that we have to accept. And then without any kind of a health insurance policy or social security scheme, it becomes so difficult. And I'm very thankful to the people who are running NGOs and all, but it feels really sad to see pictures of parents and kids sitting and crying. And I mean, if this is the government has banned begging, if this is not begging, then what is? I mean, it's not fair. You ban begging on one line and you allow it on another, saying that okay, it provides for the surgery of a child. I mean, the government has to find an alternative way wherein a common funding is there. I mean, so many film stars and all are there. They are there to be the faces of big brands. Why can't be the brand ambassador of CHD costs? Why can't they just come forward and do some programs? We'll collect the fund. We'll have a common funding, which would straight up go to the surgeries instead of the parents having to wait in the queue or put in pictures of crying babies, and that it's inhuman, I would say. So it's high time that government actually recognizes what's happening and not to take double standards here.
So we need strong
Yeah.
advocacy again, Sajni.
Yeah.
I mean, I think this is a great start. All of you need to, really muscle up and muscle your way through. We need really strong advocacy.
Mahesh, I will again insist that because first trimester there is no diagnostic tool to say that there is a congenital heart disease or not. So that is the time when a policy can be started.
That's a great
So
idea.
that
Actually.
will be very lucrative for the even insurance agencies, because there was a cradle care policy which was started by the Oriental insurance company, and they were like asking for 1,500 rupees per pregnancy, and they were giving 2.5 to 3 lakhs capping amount. But what happened? They never popularized it, and they actually withdrew it in 2014. So these kind of policies can only act once you are giving them when you cannot make a diagnosis, like first 3 months when diagnosis cannot be made, when there is a chance, there is incidence rate is less than 1%, when there is a chance of anomaly scan and the abortion. So that is also a good possibility. So I think that is the best possible way for the insurance. We have to aim at the first trimester insurance, health insurance.
Exactly. Yeah. Together, I hope we'll be able to make some change and we'll push the as far as possible. Like I guess all the people, everyone, all the CHD, the total CHD community, the doctors, the parents, the adults, if we stand together, I mean, it is a thing that has to be addressed. So something might happen in future. I don't know, but still. And here are some very technical questions that has come up, like. Do some medicines cause problems in heart rhythm? Yeah, that is one question that has come up. Do some medicines cause problems in the heart rhythm? Is it possible, like some medicines might cause this?
Navneeta, would you like to take the question?
Yeah, pardon me. Can you please repeat it once more? Like
there was
medicines
a question.
causing?
There was a question from the patient subject asking
I'll
what
repeat the
medicines.
question. Do some medicines cause problems in heart rhythm?
Okay. So that's a very good and very relevant question, I would say. So we can look at it from 2-3 different points of view. One is, even in general population, there are some medicines, quite unrelated medicines, which even when given to normal population can cause changes in the heartbeat. That is one thing. Second is, if we look at congenital heart disease population, some of them might already be on some medications, and there might be other medicines which can interact with these medicines and then cause heart rhythm abnormalities. The third, I would say, aspect is if some congenital heart disease patients are on some particular medications, certain changes that happen in the body can push them to have some, rhythm or heartbeat abnormalities. Like, if a patient is taking a diuretic like furosemide, which we call Lasix, and if they simultaneously develop like vomiting or diarrhea or anything, there will be more loss of what we call electrolytes from the body. And like potassium, you lose more potassium, and then that can lead to heart rhythm abnormality. So even without a disease, you're already on one medicine, and some change in your body can cause heart rhythm abnormality. That is one. Two is, suppose you are on some medicine like because furosemide is one of the commonest medicines, so I would go with it. You're on Lasix and you had a fever or an infection, and you were given some antibiotic, which also has some ability to change some particular things on your ECG or the rhythm of your heart. And then, in the background of already taking Lasix, or some children are on digoxin. So in the background of Lasix and digoxin, there could be even some antibiotics which can cause changes in heartbeat and push you into problems. So whenever you are on medications, already cardiac medications, and you're taking another medication, it is important to tell the prescribing doctor that you are already on these medications. And another point is some heart diseases, some children with heart diseases, have some residual abnormalities which can predispose them to heartbeat abnormalities, like even repaired tetralogy of fallow patients who have some, most of you will be aware if you have tetralogy, that even if after repair, a subset of patients can have like valve leaks and a little bit of dilatation or enlargement of the right side of the heart. And some of these patients, like if you have 100 such patients, 1 or 2 might anyway be at risk of a heart rhythm abnormality. So with that underlying heart abnormality, you're taking a medicine which can precipitate a heartbeat abnormality that can push them into such sort of an issue. So there are certain medications like that, and most of the doctors are aware about it. You would have, at least some of you would have listened to it during the pandemic time, and there was a lot of discussion on chloroquine and the heart abnormalities that it can cause, azithromycin, another antibiotic, which can cause heartbeat abnormalities. So there are drugs out like that. It is important that you mention to any healthcare provider what your underlying issue is and what medicines you are on whenever anybody is prescribing a new medicine for you. So that can help avoid a lot of such problems. I hope it clarifies a little bit.
Yes, ma'am.
Absolutely.
Yes. Yeah, absolutely. Like since we have like taken your lunchtime as well, I'm sure most of the doctors will be hungry here, so sorry about that. But it has been a really useful session.